Continuing on this very important issue of how we enhance care across the spectrum of progression of people who have dementia, it's a great pleasure to introduce our next speaker, who is Mary Beth Gallagher. She's a board-certified psychiatric nurse practitioner and director of Hospice of the Valley Dementia Program in Phoenix, Arizona, and she's going to talk to us about an uncomfortable issue for many people. Many people avoid talking about this at all, but it's critically important, and that is the issue of end-of-life care and some advances in the way that it can be delivered and presented.
Thank you. Thank you very much. Thank you. All right, so let's start with this picture. In spite of the severe impairments that accompany end-stage dementia, the good news is people can experience joy, love, respect, meaningful connection. And here's two of our little certified pets that are sitting on the bed of a person, and I know that would be very therapeutic for me. So let me give you a little bit of background. Hospice of the Valley is the largest nonprofit hospice in the United States. On any given day, well, we're in the Phoenix metropolitan area, so think about that. It's a retirement destination for all the colder climates, including Canada, right? So we have a lot of older adults there, and on any given day, we usually have about 3,000 patients on our hospice service, okay? Well, now, with healthcare changes, our census is now down a bit to 2,200. But on any given day, we probably have at least 600 who are receiving hospice services because they're at the end of their life with dementia. And then we have at least another 500 patients who are on service for cancer, cardiac, pulmonary, renal, but they too have dementia. So the reason I'm sharing those numbers with you is to say that if each one of our patients and their loved ones are our greatest and most noble of teachers of what we're doing right and where we still need to improve, then we've had a lot of teachers, and I want to share with you what we've learned along the way. So just to get on the same page, what's that last year of life looking like for Alzheimer's disease and related dementia? So we're going to generalize here because some of the frontotemporal degenerations appear a little differently. But essentially, we have a person who has very profound memory deficits, speech is limited, total functional dependence, incontinence of bowel and bladder, and an inability to ambulate, or when they do get up, they fall down. So what we have here is a very, very vulnerable person who's dependent upon us, our knowledge, our skills, and our compassion in order to get through their day-to-day. So here's what we know. We know that Alzheimer's disease and related dementias are a leading cause of death. We also know that they're commonly unrecognized as terminal conditions. We also know that most proxy decision makers report that comfort is the primary goal of care for someone with advanced dementia. That's what we know. But here's what we see in our real world. Individuals with dementia have fewer completed advanced directives. That's craziness. They have more distressing symptoms that are amenable to treatments. I mean, this is pretty easy, particularly less effective pain. We see that they have more costly and burdensome interventions that prove to have little to no clinical benefit. As Katie so beautifully illustrated, a lot more transitions of care, particularly emergency room and hospital visits, that absolutely can be avoided when we know better, and they have less use of hospice services. So the challenge becomes for all of us, how do we bridge the gap between the care that people say they want, but what they actually receive? And for those of us in end-of-life care, how do we provide the same excellent end-of-life afforded those people who have cancer and cardiac disease? How do we provide that for people who have a dementia diagnosis? So Hospice of the Valley is not the only person that's doing good work with palliative and end-of-life dementia care. Many of these folks are doing, this is just a smattering of examples of people who are doing great work. And we know that the literature consistently says that there are certain modifiable factors that consistently lead to improved outcomes. And yet, why aren't we doing them? Some of the modifiable factors are clarifying advance directives, counseling the healthcare proxies about disease progression, common complications that arise, treatment options, symptom management, and use of hospice. So here are things that consistently are shown in the literature to work. So back in 2003, Hospice of the Valley looked down the road and realized with our older adults, particularly in the Phoenix metro area, that we needed to ramp up. We needed to become dementia capable, you know. We've started to see that our hospice people were going, what's going on? We're getting all these dementia patients. Look, I'll do cancer, I'll do renal, I'll do pulmonary. Don't give me the dementia patients. I don't do them. Can you find somebody who wants to take care of them? So we really decided that we needed to do very aggressive education and support for all of the disciplines involved. So back in 2003, we decided to create the dementia program, and it originally started with the most challenging patients who had dementia diagnosis, that we'd provide in-person consults, because it's that teachable moment, or telephonic consults, and now we're doing a lot of virtual visits using an encrypted form of like Skype. We decided we needed to do widespread discipline-specific education on best practices in palliative dementia care and create materials that supported people when they were out in the field, not only professionals, but the family members. And also we decided that there was a real lack of innovation, and so we started creating that ourselves. So here's just a sampling of what we did at Hospice of the Valley. First of all, the key word in the first bullet is realistic. Clarifying realistic goals of care. People who watch television have misperceptions on what resuscitation looks like. Disease progression, what does this look like as it goes further down the road? What are the common causes of death? What are the common complications so that we can anticipate, recognize them early? Maybe we can prevent them. What are the risks and the benefits of every single medication we're administering and all of the treatments that we're providing? Some of this started to look like we were almost neglecting as we're discontinuing medications and saying no to hospitalizations, et cetera. But actually what it was turning into was reframing and saying, let's give them aggressive comfort care. Non-pharmacological interventions, a lot of folks didn't know how to implement these, and so we started to really educate people on how to do this and also giving them the tools so that they truly be successful. And we started aggressively educating the caregivers, empowering them to do the very best that they could and giving them the resources to do so. So some of the customized educational programs, as Katie was saying, you know, there's a lot of people out there who are working with folks who have dementia, and they're trying to do the best they can, but they just don't really know how to do it. So part of our mission was that we started to go out into the community and do grand rounds at hospitals and private medical practices. Also, we started to share our knowledge with the first responders who were getting so many calls. We also decided to educate any medical resident in Maricopa County, the Phoenix metro area, and say, offer them free education to come to Hospice of the Valley and to learn about hospice and palliative care, particularly with dementia. And so we would have didactic education and then experiential doing rounds. We also realized we have to educate the medical students, the baby doctors as they're coming up, and prepare them for this, and the same with all of the other disciplines. We started to reach out to certain cultural organizations because we realized that hospice is only used by certain groups and not so much by others. Faith communities, the lay dementia caregivers, the long-term care facilities, God bless the direct caregiver, and the CNAs, who were the hardest working people and the lowest paid, and they really needed more support and education. And publishing also this work. So really getting out there, because we're downstream and we see all of the unique perspective of being in hospice is I get to see the results of the care or lack of that's happened all the way upstream. And so this is a way to help, from a systems perspective, improve care. So some of our really emphasized topics would be, what are the goals of care? the most critical question, and really starting to spell out healthcare directives, really helping people with the pharmacological considerations. Behaviors, distressing behaviors, are some of the most stressful elements of being a dementia caregiver, professionally, lay caregivers, and also, of course, for the person who has dementia. And also, again, non-pharmacological approaches. So, as an example, what are the goals of care? Initiating the conversation, having the difficult conversations. Is the primary goal comfort? And 99% of people say, yes, of course. Let's do a poll right now. If you are at the end of your life and you have advanced dementia, how many people here want aggressive medical interventions? Please raise your hand. High. Okay, one person. So, okay, thank you. So, you know, the thing is, if the primary goal of care is comfort, and meanwhile they're winding up in the hospitals, etc., can we do any better? Yes, we can. So one of the ways that we do that is by reviewing the risks and the benefits of any new diagnostic workups and therapeutic interventions. Has anybody here tried to do a colonoscopy prep with a person with moderate to advanced dementia? Yeah. So, and then we provide ongoing support for the proxies in pursuing aggressive comfort care. And it's so important to support the people strongly and along the continuum, because as the loved one, it's very difficult for a loved one to say, no, don't admit my mother to the hospital. No, don't put a feeding tube into my mother, because it comes across as neglect, perhaps. Whereas when you understand more fully and you feel supported, you can see that perhaps that is the best decision for this individual if they state their goal of care as comfort. So doing all of this rather than what the research tells us is burdensome, costly, and futile aggressive interventions that don't enhance quality of life. So again, healthcare decisions. Here are the things that we really hone in on. Well, CPR is pretty easy, right? That conversation we have with a lot of folks. But what about hospitalizations? Given the evidence that Katie's presented, does that sound like something that your loved one would want? Antibiotics, another one. How many times are you going to retreating the infection that's coming back? Or is that not perhaps biology taking over and telling us what's going on? And feeding tubes, there's huge variation geographically on the use of feeding tubes. And yet we know that the research tells us that feeding tubes do nothing for folks with advanced dementia as far as prolonging quality of life, preventing tissue breakdown, etc. Also, the literature tells us we can't have this conversation once. This has to happen many times when things are relatively stable. Each time we start to see that the person is declining more and as complications arise. And if we revisit these things at these moments, we find that these proxy decision makers feel a lot stronger and more peaceful with supporting these decisions as they move along. And then when we don't do it, what happens is in crisis, they revoke the decision that they made earlier. So what are some of the palliative pharmacological considerations? Again, we have to review every single medication that the person came in on and take a look at it and go, at this point in time, at end of life, what's the payoff here? So once again, I have a unique perspective being in hospice because sometimes the care can be quite fragmented before hospice, and so I get all of the med sheets. And it's so interesting when a 95-year-old who's maybe 100 pounds comes in with 2 pages of meds, 3 antihypertensives, of course a statin, you know, the anticoagulants, meanwhile the person's such a high fall risk. And so it's very difficult to say, shall we taper or discontinue these medications? But when we do it from a risk-benefit analysis and really discuss best practices, many of the time the family is quite relieved. And anecdotally, how many patients have I seen start to blossom? And have I had to discharge from hospice because they do even better once we've streamlined their medications? Also, Katie was talking about anticholinergics, and so yeah, we need to look at some of the medications that they've been on for a long time and say, are they potentially inappropriate at this point? You know, Beer's Criteria 2012 is very helpful. And some of the medications I've found, even though they're not blatantly anticholinergic, they have the stealth anticholinergic properties that when you put a bunch of these meds together. Same thing when I see meds coming in lots of times from the community, I see patients on quite a few benzodiazepines that aren't necessarily in the best interest of someone with dementia. Something that I'm just crazy about is identifying pain. Pain is terribly underrecognized, terribly undertreated in people who have dementia. The literature repeatedly lets us know about this. And so it's so important to anticipate, to think of this person holistically and say, could they possibly have some chronic pain due to any number of factors? And you know, those of us who are in dementia care, we understand that if a pain medication is written PRN, it does stand for patient receives nothing, right? Now, if it's a benzo or an antipsychotic, don't worry about it. They'll get it. Check the Mars. So with these folks, many a time, you know, I always want to err on the side of comfort, and so I will prescribe, I will schedule pain medications with these folks and then check them back in a couple of days and just say to the direct caregivers, are they doing a little better, a little worse, are they staying the same? And almost consistently they seem to be doing better. And then of course it comes down to antipsychotics. We know about the FDA black box warning. For us at hospice, obviously comfort is the very highest goal. And so for our folks, if they're having psychotic features, but the psychotic features aren't disturbing to the patient, not the family, to the patient, then we're not going to give them an antipsychotic if it's not disturbing. If I'm seeing my dead relatives and they're talking to me at the foot of my bed and it's making me happy, yay. You know what I mean? And so then we do more support with the family. But obviously if it's distressing, I'm a Catholic schoolgirl, so if Satan's at the foot of my bed saying, Mary Beth Gallagher, I'm coming after your soul, give me some haloperidol, please, I'm begging you. You know? And good luck. I hope it works. So we're going to treat the distressing psychotic features, but once that's prescribed, we're going to keep saying, can we start to taper it? Can we pull it down? Can we pull it down? And try to get them off it as quickly as possible. Okay, demystifying behaviors. So we try to share with everybody what we believe, which is that behaviors have meaning. They're the only effective form of communication. A person who doesn't have language, insight, judgment, reasoning anymore, the only effective form of communication they have to say something's wrong. I'm experiencing distress in body, mind, or spirit. And so we look at this, and instead of treating the behavior and getting rid of that symptom per se, we're looking for the unmet needs, the discomfort and the distress, and trying to treat that. Also, we try to emphasize the practice of non-pharmacological interventions first. There are so very many of them that we can use. And as leadership in the hospice, if people come to us and they're looking for interventions and we're talking and teaching to this point, it really helps implement the practice deeply. This quote, antipsychotic medications for the treatment of behavioral and psychological symptoms of dementia should not be prescribed without assessing for the underlying causes of the behavior. And so this is a practice that we're really trying to spread widely because, as you know, so many times when we get calls, all they want is an antipsychotic. Non-pharmacological interventions are my favorite thing to talk about, because this really gets to the root of optimizing quality of life, maximizing comfort, and it's so feasible to replicate. So first of all, like I said, we have to anticipate the unmet needs. If you're so vulnerable that you can't even identify what's wrong with you and then verbally express it, I need you to have good observation skills, good assessment skills, and to trial different things that are going to maximize my comfort and help me feel safe. Also, modifying the environment. Hey, we all know that folks with dementia don't perceive the environment necessarily in the same way that we do. The classic example is the televisions that are on. How many of you watch television news in the evening and when you click it off you go, I feel so much better about the world? I really, human beings are incredible, aren't they? You know, and then here we have, you know, so many of the folks with dementia, the electronic babysitter is the television set, and they're exposed to all of this poison, so to speak, and then we wonder why they're distressed. And so we understand, and Florence Nightingale was the queen of this, of saying we must modify the environment to optimize well-being of the person. But also using skillful caregiver approaches. A lot of this stuff is so simple, so innate, so intuitive, and yet because I find that because we've medicalized dementia, we've forgotten about that person inside, and that when we use just our basic personhood and mindful approaches, how much better we can make situations. We're real big on sensory experiences. Chocolate is probably the most important medication that we use. Music, we aggressively use individualized music for all of our dementia patients, particularly during personal care. Whenever certain symptoms start to arise, we always see if we can use music and non-pharmacological interventions first, and then if we need to use medication, we use them together. I believe that there's a synergistic effect. And it's so important, you know, being in hospice, some of my greatest lessons have been that until we draw our last breath, it is very important for us to have reciprocity with the world around us and the people in it. And so even if I have really advanced dementia and no longer have verbal skills, isn't it important that I'm able, given an opportunity to express myself and to share connection with you? And so we want to provide meaningful engagement for those we serve. And the way that we do it, Katie was talking about some of these forms. This is what we use, an About Me form. Being a nurse, if you can't use it short and sweet, it's not worth anything. If it's getting stuck in a chart and you can't use it, no thank you. But this is right above the head of the patient's bed. It's not a HIPAA violation. And so even if the cleaning person is in there or the dietary person, it tells them who this person is. If you don't know who you're taking care of and you're caring for a person with advanced dementia, then quite simply you can't provide excellent care, period. It's not a cookie-cutter approach. It's not a one-size-fits-all. This is highly tailored care that we must provide. So some of the customized non-farm approaches that we do is, it's quality indicator that when you come on service, this About Me form has to be filled out so that we know who we're taking care of. We have an SOS kit that stands for stimulation of senses. It's got everything: chocolate, music, aromatherapy, visual things that will make you happy. Individualized music, like we're using the music in memory, the iPods, iPads. We just decided that certain CNAs have a knack for really knowing how to be present with our folks with dementia. So we created a program called Quiet Moments. And when we get calls for people who particularly have challenging behaviors that people are struggling with, we send in one of our Quiet Moments CNAs. And it's like that sensory, the SOS kit I was telling you about, only it's SOS on steroids. And they come in with all of this stuff and they try to find what sparks this individual. And then when they find it, it becomes part of the daily recipe of care. Same thing in hospice. One of our greatest jewels is that we get these blessed volunteers. And so we've also provided specialized training for volunteers who love people with dementia, and they're called our Memory Corps volunteers, so that they're not only present with the person, but they're really actively engaged. And pets. Thank you, our furry four-legged angels, who provide such comfort to our dementia patients. For caregiver support, a lot of the research lets us know, boy, we can empower these caregivers and really help delay institutionalization, optimize well-being in the dementia caregivers, and so we provide lots and lots of education, not only about dementia, but how to have meaningful engagement. And then the last part of the education, it's a 3-hour module, is how does the caregiver care for themselves? Really important. Also, we do caregiver support groups for the rarer types of dementia, particularly the frontotemporal degeneration and Lewy body groups, because they have specific issues. We do caregiver grief assessments. Our social workers, you know, quantify the outcomes and try to really target interventions, and a lot of self-care techniques, like I say. So, what's the big deal about hospice? Well, the benefits of hospice are here. When we use hospice, lower rates of restraints, feeding tubes, IVs, hospitalizations, more effective symptom management, the interdisciplinary team is available for support, respite care, really important on the day-to-day basis when you're a dementia caregiver. Dying in a place of choice. Pick a place you want to die. We're going to do our best to try to make it happen, even if it's under the tree in your backyard. Lower health care costs, and the families perceive higher quality of care in dying. Unfortunately, hospice isn't even used by half of people who are dying with dementia. We can do better. We need to let them know that this service is available. So do we do it perfectly? Nah. Improvements are definitely still needed. Feeding tubes are prevalent in certain regions. Observational tools for pain assessment still aren't being used as widespread as we'd hope. Antipsychotic use is still high in certain areas. Hospitalizations, as Katie said, we still need to work aggressively on this. We need to work on these transitions of care, care coordination, and families really need a lot more education about the dying process. And as was mentioned earlier, we look really hard for depression and anxiety and treat it, because I can't reverse the dementia, but I can try to help you be the very, very best that you possibly can be. So are there barriers to providing hospice care? Unfortunately, there are. As we said earlier, dementia is still not widely known that it's a terminal illness. So if you can spread that information, it would be helpful. Prognosticating the last 6 months of life for people with dementia, good luck with that. It's really difficult. There are so many studies that illustrate this point. And then we think about, what are the hospice eligibility criteria for someone with dementia? Well, they're not empirically based, and they were built on the Alzheimer's model of dementia. So what do we hear today? That a lot of the dementias now are mixed dementias. And does this exclude our folks with the frontotemporal degenerations at a younger age? So we've got a lot to work on and a lot of barriers. But you know, when you talk to most dementia experts, the consensus is that I wish palliative care would be offered to every single person who was diagnosed with dementia and chose comfort as their ultimate goal of care. Right out of the gate, I wish that this is what we could offer them, so that as they journey through this very difficult trajectory, that we as experts can be there to help them be the best that they can be. Whoops. So in summary, Hospice of the Valley and those we've served have benefited from this comprehensive dementia program. Okay, so you don't care about our increased referrals, but you know what? In Phoenix, guess how many hospices there are in Phoenix? 67. I know, right? Okay, so, but more importantly, staff members who said, I don't do dementia, are now saying, you know what? The dementia patients are my favorite and most fulfilling, them and their families. The clients have higher satisfaction. The quality indicators are telling us we're having higher integration. And we're starting to receive a lot more recognition for this work. So, thank you. I like it too. So here's a couple of our recent endeavors. We opened in October the first ever, to my knowledge in the world, the first ever inpatient hospice unit for people with dementia. And it's a 10-bed, freestanding, beautiful, beautiful unit. And we're learning a lot from it. It's a living laboratory, so to speak, for me. And I'm hoping that this will be the start of something big that will go national. Also, because of the lessons that we've learned on the back end of the disease, and our wishes that anybody who wanted comfort care would have palliative care offered to them. We actually started our own palliative care for dementia program for people, and essentially it's a psychoeducational model. Also right now, one of the things we're doing is we're teaching people how to have the delicate dance. There are major changes occurring in hospice care and reimbursement. And so hospice care, as we know, it's going to change the way it looks. And it's going to make people really angry and frustrated. And so we're trying to help our staff skillfully be able to communicate with them. Something I'm extremely excited about, if you don't know MBSR, Mindfulness-Based Stress Reduction, John Kabat-Zinn, University of Massachusetts Medical School, we're teaching mindfulness meditation to our hospice workers for free, because we want to help them develop stress resiliency, stress hardiness, so that they can be the best they can be in service to those under our care. And I have a grant out now. I know UCSF is doing mindfulness meditation with dementia caregivers, and I have a grant proposal out now that maybe we'll be able to do that for our dementia caregivers as well. Because although I can't change the trajectory for their loved one, can I help them be the best they can be? And someday be able to look back at this journey, and even though it may be painful for them to be able to go, there was some beauty in it and value, and I did well. So, here's my dementia crew, and on behalf of them, I thank you very much. And again, the most important message for you is to know that until you draw your last breath, there is still beauty and laughter and joy and love and dignity when you do it right. So, thank you.